My name is Jennifer Anders. I am a physician. I do pediatric emergency medicine at Johns Hopkins Hospital in Baltimore, Maryland. And I am a pediatric ER doc and also an EMS physician. So in any kind of simulation, what's important is making it feel as real as possible. And sometimes that means having amazing technology like a super high fidelity mannequin that can move and make noises. And sometimes you're working with very low fidelity mannequins, but you can still do everything you can to make it feel as real as possible. Having devices like a syringe or an endotracheal tube that the clinicians can pick up and use and put in their hands, but also making the decision making and the mental work that happens in a pediatric case feel as real and palpable as it does in a real life patient care episode. When you're doing simulation, it's important not just to look at the case as a story or a melodrama that you're going to put on, but also think really carefully about what the key teaching points are in that simulation. What are you hoping that the participants are going to learn and internalize and walk away and remember 6 months or a year from now when they may encounter a similar scenario in their actual clinical practice? I look at the case and I try to figure out what are the couple of big ticket items that I want to make sure I'm conveying to my learners. And I start from there. And with that, it will help me chart the course of how I want to develop the case, because we go in with a plan, but you're interacting with individual learners and you may take a turn because the learners have made a decision you didn't anticipate and you have to go with the flow. So I know where I'm headed, and that helps me choose how to develop the case on the spur of the moment in real time. And it also allows me to pick what are the important devices or items that I want to have available. Are there things that I can give a little bit more realism to the scenario if I build an extra little device or bring something extra in terms of equipment to the simulation? And then the most important part of the simulation is the debrief that happens afterwards. So we obviously let participants have some leeway in giving their feedback and saying what their experience of the simulation was. But I'm always going in knowing that in the debrief, they're going to give me feedback, and I'm going to turn the conversation to make sure that we hit and circle back to those important learning objectives that I started out with for my case to make sure they're walking away with the important key points that I want them to. Chaos is part of real life of pre-hospital medicine, isn't it? So I try to bring as much of that to a simulation scenario as I can. Obviously, when people walk into a simulation, we all know that it's fake, right? This isn't real, and that takes some of the pressure off. But in reality, part of what makes pediatric care for EMS particularly challenging is everybody's baseline discomfort level. And so I like to bring a little of that discomfort back and try to bring the clinicians, the learners around to that place where their blood pressure is going up, even though we can all see it's a plastic doll sitting on a table, but to bring up some of that emotional memory that they may have of a difficult pediatric case by either offering some of the parental anxiety that is a big player in adding mental stress to pediatric decision making, or sometimes offering the incomplete or unhelpful information that parents will give when we're trying to get specific medical details out of them. They often don't give you the kind of like textbook answer that you're looking for, and you have to figure out how to communicate with this stressed out, distraught parent, and that's part of the challenge of pediatrics. I'm trying to understand why a child is having respiratory distress, and I want to know very specifically, could he have choked on something? And I start asking a parent about what he was doing right before the distress started. The parent may start going off about the immunizations that he had 3 weeks ago or what he had for lunch on Tuesday. And so when they ask questions in a way that isn't exactly clear, I try to meander. I try to offer a little bit of that realistic frustration that parents sometimes give us in pediatric clinical medicine, and help them hone the questions that they ask. And then also sometimes it brings a little humor to the situation that relaxes everybody and lets them get more into the realism. Sometimes I think a simulation is successful when the learners walk away feeling a little more empowered, a little bit more ready to handle a situation like the one we had in the scenario, or maybe a similar adjacent kind of situation. I want them to feel like, oh yeah, I've been there before. I've got a little bit of muscle memory of what to do if I find myself in this particular kind of jam in the future.